for the invitation. I'm very honored to be here. And so my topic is what do the guidelines say? And I will talk about the European Society of Cardiology guidelines regarding transcatheter therapies for patients with valvular heart disease, and namely for the patients with mitral regurgitation and tricuspid regurgitation, even if we have much more data regarding mitral regurgitation. In this year, 2021, we actually have had two guidelines published regarding the management of valvular heart disease and the treatment of acute and chronic heart failure. And these guidelines, I have had the honor and the task to chair the European Society of Cardiology guidance on heart failure. And I had to we put together 31 authors coming from 18 associations and working groups. And the guidelines are very long, 128 pages, but we also had the guidelines on valvular heart disease, where the cardiac thoracic surgeons were also largely represented, and little bit shorter, but not less important with respect of valvular heart disease. Now, what do the guidelines say? Let me start, because I co-chaired with Teresa McDonagh the guidelines on heart failure. Let me start with the central figure of the guidelines of heart failure. And this central figure shows at least two things. One is that we now have 4 drugs for all the patients with heart failure and reduced ejection fraction. And the other thing is that we have many options of treatment of the patients based on their severity and based on comorbidities, cardiovascular and non-cardiovascular comorbidities. And as you see here, we have aortic stenosis with class 1 recommendations, but we also have mitral regurgitation with a class 2A recommendation for transcatheter therapy for secondary mitral regurgitation, and we will come back to this. The valvular heart disease pointed out an aspect which is also included in the heart failure guidelines, though a little bit less important, and this is the heart team. The heart team has a central role for the evaluation of the patients, considering all the different aspects of the patients and all the different treatment options. This is the algorithm that we had for that we have in the heart failure guidelines for the treatment of secondary mitral regurgitation. You see that the only class 1 indication regards the heart team, that has a central role at the beginning, and then also when we have to decide which treatment to do. And we have 3 major aspects for the treatment of secondary mitral regurgitation. First thing is the patient who has concomitant coronary artery disease and where cardiac bypass surgery is indicated. In this case, concomitant mitral valve surgery is also indicated and should be considered. Then there is the patient who needs medical treatment and possibly who may need CRT, and this must be optimized before a final treatment because must be optimized because you may have a significant percentage of patients who have a regression of the reduction of the severity of mitral regurgitation because of treatment. Then we have the patients who, despite no need of coronary surgery, revascularization, despite optimal medical therapy and CRT, these patients may still have significant secondary mitral regurgitation. Again, the art team has a central role, and actually we have 3 or 4 options. The most important is that the patient may have echocardiographic and clinical characteristics corresponding to those of the patients enrolled in the COAPT trial, and these include ejection fraction above 20%, ventricular and systolic diameter below 70 millimeters, systolic pulmonary artery pressure less than 70, absence of moderate or severe right ventricular dysfunction or severe tricuspid regurgitation, and hemodynamic stability. When the patients fulfill the COAPT-like criteria, we know from this trial that these patients may have an improvement in the outcome if treated percutaneously with edge-to-edge mitral valve repair. So this procedure should be considered in these patients. When the patients do not have the COAPT-like criteria, surgery may still be considered if they are at low risk, or percutaneous correction may be considered if to improve the symptoms and reduce the pulmonary pressure. Here are the results of COAPT to the right compared to those of MITRA-FR, and the main interpretation is that this discrepancy in the results was caused by difference in the enrollment criteria. Here is a study group that we gathered with a colleague from other institutes in Europe, and these are observational data. So we just compared the outcome of the patients fulfilling the COAPT criteria versus those who did not fulfill, and you have a significant difference in cardiovascular mortality and heart failure hospitalizations between the two groups. These are data from COAPT, and again they point out that once the patient fulfill the criteria that they had in this trial, you have an improvement in outcome independently from any echocardiographic parameter. These are the basis for the upgrade of percutaneous, transcutaneous edge-to-edge repair from an indication 2B, which it had in the 2017 valvular heart disease guidelines, to an indication 2A, so should be considered that it is in the heart failure and as shown here in the valvular heart disease guideline. And here are the heart failure guidelines. What else? A major problem that we have in clinical practice is that if we consider the enrollment criteria of COAPT, there was a major selection of the patients. That is to say, many patients with severe mitral regurgitation do not fulfill exactly the criteria they have in COAPT. The important thing is that these patients, even if they do not fulfill exactly the criteria of COAPT, or even if they have criteria similar to those of the MITRA-FR, as shown here, an EROA equal or less than 0.30 square centimeters, a left ventricular and diastolic volume above 96 ml per minute per square meter, these patients do not benefit from the point of view of the outcome compared with guideline-directed medical treatment, differently from those who do not have the MITRA-FR criteria. But nevertheless, these patients may
Dr. Metra, we have only 2 minutes more for a presentation.
And exercise capacity, as shown here, group 1 versus and group 2 patients. So the important thing, these are patients from our center. There are patients who have no reverse remodeling after our centers in Pisa and San Raffaele and other hospitals. But so the patients who do not have reverse remodeling have a poorer outcome. but nevertheless, these patients may still have a symptomatic improvement. And these are data from German study groups showing that even the patients with right ventricular dysfunction, although they have a poorer outcome, they have a symptomatic improvement with percutaneous treatment of mitral regurgitation. Therefore, we come to the 2B consideration that percutaneous edge-to-edge mitral valve repair may be considered to improve symptoms in carefully selected patients with secondary mitral regurgitation, not eligible for surgery or coronary revascularization, who are highly symptomatic despite optimal medical treatment. We have trials ongoing. Reshape HF2 is ongoing and will give more results regarding the effects of correction of secondary mitral regurgitation on outcome. Here are many trials ongoing with the Edwards or the Abbott devices, Pascal and MitraClip and then Sapien and Tendyne and so on. And they will also give further results regarding the benefits of treatment of mitral regurgitation. Here are the valvular heart disease guidelines, and they are completely aligned with our guidelines. Another advantage of the valvular heart disease guidelines compared to the heart failure guidelines is that in the valvular heart disease guidelines, we have an algorithm also for the treatment of tricuspid regurgitation. And transcatheter therapy of tricuspid regurgitation may be considered according to whether the patients have symptoms, right ventricular dysfunction or not severe right ventricular dysfunction, and transcatheter therapy may be considered. We have also trials ongoing regarding transcatheter treatment of tricuspid regurgitation, and therefore the situation where we are is that we have a class 1 indication for the heart team, so the heart team must be always involved in the decisions taken regarding treatment of mitral or tricuspid regurgitation. We have a class 2A indication for transcatheter treatment for secondary mitral regurgitation when the patients meet the COAPT-like criteria, so it should be performed. And we have a 2B indication for transcatheter therapies when the patient doesn't meet the COAPT-like criteria. Again,
Dr. Metra, do you hear me?
Transcatheter treatment of tricuspid regurgitation
Dr. Metra, do you hear me?
May also be considered in symptomatic patients with secondary tricuspid regurgitation who cannot be treated surgically and with high expertise by the center. Thank you for your attention.
Thank you very much.